Thank you. It's a great honor to be here and share with you our experience about pre-hospital care in a small country called called Malawi, in a continent that has more than 50 countries, but sometimes we're confused and it seems like it's like a whole mixture of it's like a monotonous continent, but definitely it's very diverse, and there's a mixed bag of what we can have in terms of hospital care. So my role today is to actually share with you a bit of the chapter that we're actually creating, starting pre-hospital care, not really starting, but actually enhancing the pre-hospital care services that we have, and then also share a bit of the jewels of the investment from the community that are coming up and need to be harnessed into activation of an emergency response as well as transportation. So yes, Zambia is close to Malawi, west border, but definitely Malawi is very small, but is the warm heart, and in the right side of the left chest, so we definitely are the heart. And I'm from the second largest city, Blantyre, which is in the southern part, and currently also involved with the floods and the cyclone Ida. We always chart the Guinness Book of Records for the widest patient-to-doctor ratio. So apparently, it's an honor to be around in my Malawi health system because I tend to work in the ivory tower in the central hospital, and my background was internal medicine, infectious diseases. But looking at the need, I came out been asked to look at emergency care, and evidently it brought me into where the bulk of the care is provided in primary care. But not just primary care, but to the rural people. 80% of our population are in the rural parts of Malawi. And our country provides free healthcare services. We don't have a national health insurance. So we're heavily dependent in terms of financing from our health budget, which is 11% of our health budget. So hardly keeps the health services working, and therefore resource constraints is always an issue, not just human resource. But that's why, personally, I think as we're talking about pre-hospital care, we need to think of the jewels of harnessing the community investments that have been utilized over time, but are also coming up as we advance in technology. So, what are we doing? This is the structure of the African Federation of Emergency Medicine, trying to have a framework so that we can standardize pre-hospital care and be able to have a good system that each government can be able to go through. And the biggest issue that we notice is that access to pre-hospital care services is the most important thing that we need to start working on. Toll-free public access numbers are rarely available. In my country, I'll show you later, can be very complex for you to be able to access emergency care services. However, we should say the community, the police and fire have been amazing at offering pre-hospital care. They have been the backbone of keeping people alive at the road scene in the community and continue to do so. And sometimes it's sad because they haven't been invested with basic life support skills or even first aid skills. They do it out of their own ingenuity to be able to offer this care. The mixed bag of creating a health workforce and why we prefer the Anglo-America model is the diversity of the workforce that we would include. So if we look at the trained professional who we would like to incorporate in an emergency health medical service, we need to think about the structures, and we're still defining who will actually recruit. Because if we're going to recruit, as we have at the moment for our pilot emergency medical service, which I'll talk about, we're taking already rare health professionals, the paramedical or physician assistant or a nurse who is interested in pre-hospital care to actually be trained in emergency medical services. Yet there are a lot of unemployed youth. Should we be tapping into that workforce, those who have high school qualifications and maybe train them. Those are things that we keep on talking about and discussing. How are we going to get the workforce of our emergency medical services? I'm going to share a bit about the emergency transportation structure, and therefore that will help us get into what exactly is this pre-hospital care system that we're able to do so, to provide. Yes. So let's go into the community. With development comes the need to improve road structures, to compete with the developing world for skyscrapers, and also the best model of the car. But road infrastructure comes with also people becoming free in the way they think. And what happens? On the roads of Malawi, we always find that we've got roadside markets, informal markets. And so the mama is selling her lovely fresh fruits and vegetables to the passerby, but also to the road, to the bus passenger, as well as the motor vehicle, people like me who will be traveling between Blantyre and Lilongwe, and I would want to have some Irish potatoes as well as carrots because they're cheaper in the rural areas compared to the urban areas. But that's a health hazard. Injuries, and that's where we come from. So the World Bank has actually, in terms of the improvement of road structure, and this is happening in many countries, there's a north to south corridor from Cairo to Cape Town that is being constructed, and there's a need to improve our emergency medical services. So the first thing that we've noticed is access. And as you can see on the left side, on the my right side, is that access was complex, and you needed to have a directory. But now we have a toll-free number that is currently being piloted and can be accessed from all the mobile networks that we have. And mobile technology is very important in Africa. We may not have shoes, but we've got a smartphone. It keeps us alive and in touch with the globe, and we love it. So, WhatsApp is amazing. It has brought people together across diversity and across various complexities of modern society. So if you're going to Malawi, or even now, I'm still in touch with home because of WhatsApp, whether by call or video. Now, what we've noticed in the health system is that actually, while we're trying to develop a whole toll-free number, the WhatsApp system is actually providing an informal communication channel for emergency care response. So how is that happening? Groups, those big groups where you get lots of texts, but you also get photographs. So I've given a snapshot of this. Was a highlight on our formal group of doctors, where someone told us about an incident that is in the central part of my country, but they were already informing us as what was actually happening. So the statistics were happening, and the injuries were being presented, and the receiving hospital was actually ready to provide the relevant care. But the other bit of this social media is that photographs are shared, videos are shared, on-scene media displays. What are the consequences? Ethics. Bad news being communicated to family from social media. That's something we need to work on. Much as it is doing good, well, there are big issues going on. So there are gruesome pictures that we had to even actually have a discussion and say, hang on a minute, there should be some regulation of on-the-scene photography and videoing. So there you are. This is a roadside accident, and those 19 people were unfortunately dead. But pertinent is that we can harness this for intra-facility communication, and it does help. Nowadays, rather than me getting aggravated on when are these patients coming, we get updates of what is going on, and people are able to tell us in terms of where they are at. We're also able to provide advice, basic things done better, a primary survey. What should you do? It sounds simple for this audience, but these are the basic things that we're trying to make sure people are able to do. So that's communication, access. Now let's look at transportation. Now, as you can see, there's a step down from the helicopters and drones and everything. And we got the good old Land Cruiser. Why? Because you need to think about the infrastructure and the terrain that we have. We're in the Rift Valley. We've got lots of character with hills and various interesting muddy roads. And as you have noticed now, we do have floods. So it's important for us to always think about the type of vehicle that we will use. So fancy donations that keep coming end up not being utilized for the relevant need that was required. And then an interesting bit is what exactly should be put in the ambulance. You can see here there's a makeshift stretcher. It's just a mattress. Put on in the ambulance, and there's no first aid kit or among others. So it's the scoop and run immediately so that the patient should get to the hospital. So scoop and run has its consequences, secondary injuries. And that is another thing where education of not just community members or volunteers is required. The other bit is harnessing innovations that have been utilized and have made a difference in other aspects of pre-hospital care. And that is maternal health as well as child health care. And we are commonly discussed as in Malawi for our ingenuity for the bicycle ambulance. This was an innovation within a community, allowing them to transport patients. But there are complexities of just getting innovations and providing emergency care services. So who, where, and when need to be discussed. Because even though it's acceptable in a certain community, just into another district, different culture, different social expectations, it's not acceptable. They assume this is when I'm dead, then I travel like that. So there are things about community acceptance that we need to discuss. But definitely, in terms of sustainability, which is the main thing that usually we discuss with our Minister of Health, we've got a lot of white elephants in our hospitals, donations of things that end up not being maintained or utilized. We need to think of what is the most cost-effective transportation in the particular area, but also maintenance of the transport system. And there's a paper that discussed the utilization of the bicycle ambulance in the rural areas, and definitely it seemed to be more cost-effective, reducing the cost over 2 years by half. So what am I saying? There's a proverb that is said in Africa: if you want to go fast, go alone. But if you want to go far, then let's go together. And I feel as a health professional, I'm always learning more and more about from the community that we are serving, resilience. Even though I'm practicing high-tech medicine, among others, I need to step down to be relevant in the community and the environment I am in. There are no toys. There are limitations. I become useless to my government and to my public service if I can't adjust. So let's indeed embrace the informal community initiatives in pre-hospital care if we want to go further. Thank you.
Good evening. Craig Wiley for SmackForce News in Africa. Melinda, it's wonderful to see you again here, far away from Africa. The last time that we met was in South Africa, I think. Rwanda. No, I wasn't there, you were there. The last time we met was in South Africa. And I think as a first question from our viewers, even in South Africa, we faced with a much different system. And how do we come to conferences like what we are at today, like SmackForce, and learn from each other? How do we take what's happening in the developed world and actually apply it in the developing world?
Definitely the goodwill and synergy of the developing world community as well as the developed world is what makes us to be able to share experiences. So indeed, the generosity of donors allows us from the developing world to be able to participate in these conferences. And I would say I do have a SINMAN in my education lab, but it's just being able to practice more because of electricity power cuts, and also the relevance of using the SINMAN frequently. Definitely these conferences give me that experience and exposure to take this back and share with my community.
Then, is universal health coverage by 2030 addressing pre-hospital care adequately in the African continent?
Much as it's been addressed, not clearly. It's brushed aside. And the most important thing is that people don't know where to start. And what we as health professionals need to do is indeed capture the basic things that need to be done that will allow us to be able to provide care. Pre-hospital care is basic essentials of healthcare. And as it is being confused with issues related to non-communicable diseases and communicable diseases, that's streamlining care, not thinking of the individual who requires emergency care, timely care that needs to come to the hospital and then benefit from what is currently being thought of as universal health coverage, chronic care.
Thank you. Then the final question is, if you could do one thing to make EMS a priority in the developing world, what would that be?
One thing only.
One thing, get people together.
Thank you.
Thank you.
This is Craig Wiley, signing off from Africa.